Let me start by thanking Khalil, first Dr. Khalil Al-Khaliq, Omar for inviting me. And Khalil is a dear friend from a long time. He's a visionary, and he's always looking to the future. And I just known Omar a few days ago, and I think we're on the same wavelength. So I'll try to speak in English all the time. If you have, as we said, if some people want me to speak in Arabic, or you let me know what you want to do. So I'll get onto it. And as you can see, I'll start by an example. This is like a 50-year-old man sleeping in bed. And he develops a clot in a coronary artery, which is the main artery supplying the heart. And this clot releases what we call as biomarkers, which are the enzymes that come out from the tissues as they start to damage. Now, if the patient has a biosensor somewhere around in his body that can detect these enzymes, then what can actually happen is that these biosensors will detect the heart attack as it starts, and it will send a message to the Amazon Dot or whatever artificial intelligence technology around in the home. And this technology will signal and will alert different parties that are responsible to take care of this heart attack. Like, it will call the ambulance, wake up this patient who is not yet aware of his heart attack with maybe some quiet music so that he will not be alarmed. It will alert the hospital, the cath lab, and all his friends. And so you get the message here that this type of, although small technology, may make big differences. So all around this meeting, and other people are interested in modernizing healthcare and transformation of healthcare into a digital realm. But we all see that there are tremendous challenges, and I see that lots of the questions are about these challenges. So what struck us to go into this webinar now is that suddenly everybody is talking about these new technologies, and definitely in the Lancet, which is a very reputable scientific magazine, as you can see, they say virtual healthcare in the era of COVID-19. Now everybody's doing telemedicine and all sorts of e-health because of COVID-19. So it appears that COVID really created an opportunity by sort of not abolishing, but dissolving a little bit the barriers that were present. And these barriers are, as you can see, divided into individual, regulatory, legal, privacy, security, data ownership. So a lot of them are around. Maybe you can discuss them in the in details in another session, or maybe during the questions. But basically, I think they are regulatory barriers, the legal situation, and healthcare provider barrier, whether he's a doctor or a hospital or clinic. Why would the clinic be worried? Because of the tribal behavior of people. So hospitals would be worried that they would lose businesses, individuals would be worried they would lose businesses, and they start forming these geographical barriers, resisting these changes. So these are just some of the barriers we can discuss in more detail. As you can see, that COVID did move also some of the barriers in Egypt, and our team, telehealth response team, immediately was mobilized to move many of our units to the COVID hospitals in Egypt. And our champion is, of course, Dr. Mohammed Abdel, who is the spearhead now of Telemed, and he's been carrying this torch for more than 10 years. He's perseverant, he's determined to make things work. And our managing director, Dr. Walid Auf, our CEO, who's also managing director of Medmark, one of the very prestigious healthcare insurance and companies in Egypt. So, and you can see Walid is holding our latest technology in telehealth. So we do have a practice that has been going on for 10 years. We've been in and out of different forms of telehealth. And as I said, this is the National Telemedicine Network, which we have been working on. And there are more than 120 units now. They were going reasonably well, but accelerated after the COVID. But we've done thousands and thousands of patients in all different disciplines. So,
Dr. Wael, I'm sorry to interrupt الثانية بس can I ask you to click على في تاب أبيض كده عندنا شايفينه قدام السلايدز so if you can hide that. Okay. Thank you so much.
Okay. Thank you for that, Jan. This is just one of the examples of telemedicine, and basically telemedicine are three main things. The interactive video conferencing situation, whether it's on a desktop, a laptop, an app, a mobile, whatever it is, and sharing rich medical images like this X-ray, so sharing this, and telemedicine scopes and wearables that act as the hand, eye, and ear of the physician on the other side. So it is a communication between one point and another through a network that sorts of combines all these three interactive, diagnostic, and sometimes even delivery of healthcare, actual treatment type of healthcare. There are lots of solutions and platforms, as I said, from the mobile to the tablets and mobile cars, in ambulances, field bags, and so many different platforms are around. Telemedicine has been there for a long time, but it hasn't really picked up as being part of the strategic healthcare. As I said, you can also have telerobotic surgery and different types of delivery of healthcare. There are different ways of looking at telemedicine, but there are so many different models. It's like, it's not one tool. It's a discipline. It's an operation. It's a model. It will be different for different types of specialties, whether you're setting up in a hospital, in clinics, cross-border, across countries, homes, whether it's surgery, whether it's cardiology, whether it's orthopedics, different specialties. But you have to build the right model in the right way, in the right organized way, and using the appropriate technology. These are just some of the wearables. These are all stuff by like Apple watches and Samsung and other wearables. Sorry, just a second. My wife is here and she's watching on her tablet, so it's causing an echo file. Yeah, you have different biometric sensors and wearable technologies that can track individuals for 24/7. And so, as you can see, the individual really, as this graphic from Cell magazine shows, we're going into health 2.0 or 3.0, and the actual individual now is multi-layered, even introducing the social graph like Facebook, YouTube. It's part of the individual now, the different biosensors, the genome, the proteome, the metabolome, microbiome, and all different things that form the individual. So one example is the microbiome, which fascinates me because the human body has 20,000 to 25,000 genes of our own body, and it has 8 million microbial genes. So we have 8 million genes of microbes in our body, That means 8 million different microbes and bacteria in our body, while our own genes are 20 to 25,000. So, and this is because bacteria works with the human body to digest food and do other things. So this is even a new layer of looking at the human body in different layers of course, all this technology produces enormous amounts of data. To transform that into actual knowledge really would take something like an artificial intelligence to be able to sort out what this data means. So this slide shows different types of intelligence. Where we are now in the industry is the narrow intelligence. It's basically reinforced learning or pattern recognition, as the slide, looking at a Chihuahua dog and the muffin and differentiating between learning. So the artificial intelligence learns how to accurately differentiate between these different images. Of course, all this data also accumulates, like the Amazon and the Facebook, they accumulate enormous amount of data personalizing you, so they know what type of books you want to read, what type of merchandise you like to buy, and all this stuff. So this is just an example of how artificial intelligence secures and uses its data. And of course, this is used in different forms of medicine. The new type of artificial intelligence is machine learning, and this is moving to a different level of looking at the data, where the machine itself, rather than pattern recognition, it develops certain algorithms really beyond the scope of this talk, but very interesting going into the future. One of the very abundant or famous in medicine is the IBM Watson, which basically collects data from the human, whether it's genetics, clinical, different X-rays and images, and then compares them to all these available articles and guidelines and all of this, and can simply come up with the best possible management plan. This was the idea for the IBM Watson, but unfortunately there are drawbacks. And MD Anderson was trying this. It's one of the biggest oncology hospitals in the world, and it didn't turn out as we wanted, but they're getting there, improving the data sets and so forth. And this is just a cartoon that, artificial intelligence really has a certain way. You have to frame the objective for the artificial intelligence and not expect things that it's not understanding. So if you say eliminate environmental crisis, and actually we are the problems of the environmental crisis as humans, and the machine can come up with, okay, so the solution would be destroy humans. This is just a cartoon I did to show you the dangers also of artificial intelligence if it's not framed correctly with the proper objectives. Of course, with all this data comes hacking and the information security. We have all seen the Cambridge Analytica and weaponizing this data to hijack hospitals. And this is an industry also that's very interesting to understand and know how to go about it. So, but I'll just skip the details. Later on, if you want to know more details, we can go. So, telehealth, e-health, digital health, telemedicine, the most important thing is it is able to facilitate an unprecedented outreach and access of hopefully quality medicine, defying geography, time, and cost. And it pushes us into a new realm of medicine. As I said, so far we're working with sick care, disease, and we're looking at specific diseases and so on. We want to go into well care. And this entails the 5 Ps, which is really preventive, which is understanding what will be coming before it comes, like a hurricane. And we now know that we can forecast weather, and we know when a thunderstorm is coming or a hurricane. So we need to understand to be able to predict a disease and then prevent it from happening. So prevention is an important part. Personalizing it, making the management of that particular disease suitable for an individual, for a particular individual, and precision targeting that particular disease in this personalized or in this particular individual. And this comes with a sort of a participatory medicine where the individual himself needs to participate, whether with an app on a mobile, whether talking to his doctor, or and also different partners from the healthcare industry will be talking and discussing this patient. So it is abundant participation, which is facilitated by all the technology now present. And when I said precision medicine, this slide from Nature 2015 shows you that the top 10 drugs prescribed in the USA are not that effective as people would think. They are very expensive drugs, and they are the top 10 prescribed drugs. And you can see that that in the red are the patients who are not really affected by the medicine, and only 1 out of, I don't know, 20 or 10 or 15. So this is what we call imprecision medicine, when we give drugs to everyone in the same way. And so how are we going to become more precise and individualized? By understanding the patient, the individual. As long ago, Sir William Osler, for those of you who are non-medics, he is one of the famous pioneer doctors. And so he said that we need to know what sort of patient as well as what sort of the disease. So we need to understand the patient as well. And at one time we thought that the genes, looking at the genes, which is our personal code, will sort out everything. But after 10 years of looking at the genotype and really 10 years to discover the human genome, then we found out that this was not the only situation. The genes need to be switched on or off. So if two people with the same cancer gene, one of them can develop cancer and the other not. And the reason is there are so many gene switches, switching them on and off, like the environment, what you eat, stress, cell signaling, hormones, and all of this. Why I'm saying all these things is because these are the targets of the future. This is why we're looking at technology, not to deliver the same type of medicine, but preventive, predictive, personalized, and precision medicine. This is what we're looking for. So through these technologies and studies, we are now able to transfer in a fetus, actually before he becomes a fetus, we can remove in things like Graves' disease, we can remove sick genes and put healthy genes to come up with a better child, a more healthy individual. Forecasting, FitzRoy started forecasting when on an expedition with Darwin in 1820. And as I said, it's like looking at hurricanes, and it's actually like looking at what we have been doing in this recent history at the COVID and all these projections. This is one of our New York's projections. All projections were here, and the one we actually followed was this violet one. It really shows how we are very poor at predictions. And so the red, green, orange, yellow are all predictions made by McKinsey, by Johns Hopkins and others, and by Columbia. But actually what happened was this violet, things, whether we were able by distancing and home lockdown to change these models, that's another thing. So we had these models, and they said, if you keep on moving in crowds, this is what will happen to you. And then once we stayed at home, this is what happened, and the curve went down. So as I said, technology is a cornerstone of the future, and to be able to deal with this, all these biosensors, add-ons, telemedicine, and you need hyper-efficient aggregation with artificial intelligence and platforms to be able to reach decisions in a 24/7 individualized way. and to be able to move from sick care to well care, to be able to really be free of disease, age gracefully or not age at all, feel well and be satisfied. And if I go to age, this is also one of the futuristic challenges. Ever through history, everybody was trying to find the fountain of youth. And we do have examples. So this bristlecone pine, a tree in California, lives for more than 5,000 years. So it ages. I don't know how they came up with 5,000, but at least it lives for a long time. 5,000 years is the estimate. Also, giant turtles live for a long time, sometimes reaching over 300 years. And now there are tremendous studies that are helped by all these new technologies and wearables and tests that indicate that there's a difference between chronological age and biological age, where chronological age is the actual age estimated when you are born. So you're born on this day, and then after so many years, you're this age. But biological age is how healthy is your body at that age. This is just one of the studies that shows that looking at individual aged 38 years, some of them were more healthy than others, some of them were less healthy. So the median was around 38, but you have people that have a physical or situation like a 30-year-old and others that go to 45 years old and more. Not only as an individual, but each target organ has its own biological age. And then you went into the, so part of the technology would be looking at these ages and targets and apps that look at your liver age, your status of mental status and all this. So these are all futuristic compartments for technology and for marriage between healthcare and technology. And in 1956, people thought of, scientists looked at, what if we inject the plasma of young mice into older mice, would they be younger? And this study was stopped after some time, and then it came back again in Harvard and Stanford in 2014, looking at the plasma and also looking at what we call CAR T cells, which these are like immunity cells in the body. I'm saying this because this is the same thing we're looking at COVID with immunity and with injecting plasma of people who are recovered and so on. So these ideas are the futuristic ideas. And I know that a few of you are from pharma, and some of the questions were about pharma. So you can go into biotechnology, and I mean, there is a big chance for pharma. And then you go to human upgrades as well. So there are all sorts of devices now from technology that help humans. This is a quadriplegic, so he's paralyzed from his waist downwards. And of course, he can move around by an electric chair, but it's healthier to move or actually mimic walking, because this is better for the heart and the lungs, because people who sit in chairs all their lives will die early from heart failure and lung failure. So this is not only a better way of moving, it helps your other organs be healthier. This is, again, a mechanical heart, a small mechanical heart. We have like 45 people in Aswan with this type of heart. Once the heart really is in a very bad situation, then we can put this machine, and it's very small, and the patient can go back to his work. Getting towards my last third of this talk, I know Omar wanted me to finish. We started late, but Omar wanted me to finish around 11:15. So we are in the age of acceleration. So everything is moving very fast, and this is an important factor, because with this pace of change, we need to be also moving very fast in our how we tackle what's going on, and look at adaptation to all the what's happening in the technology and the world around us. And we take an example from the tropical forest adaptation. You can see in the background these long trees competed for the sunlight, and so they started becoming very long, while these young, shorter trees competed by increasing their leaves. So they have wider leaves, but they are shorter, and these have smaller leaves, but are longer. And these are the tropical forest adaptations, natural selection. The same with the desert. You have no leaves, and you have a body containing all the water and spikes. Not only that, but it adapts according to the season and the amount of rain. So if you have much more rain, you will have flowers. If you have no rain, you will have this type of adaptation. It's very important because we have Wadi al-Hitan in Egypt. This was basically a lake connected to the sea, and then it dried. And if you don't move fast and adapt like these waves, you get stuck and you get stuck in the desert. And with this fast acceleration, then we need to adapt fast. And we have seen how something like Uber plus the freelance drivers here competed with taxis. And this was a troubling situation for taxis. And then, but the issue is, by time, possibly these happy drivers of Uber will be disrupted by self-driving Uber cars. And then maybe when there are abundant of self-driving Uber cars, you don't need to buy a car. You would schedule the Uber self-driving car to pick you up at specific times and get you back home and so on. So why would you buy a car? So the automotive industry altogether, car industry, manufacturing industry, would start thinking about what type of cars do they need to develop? Do you need to? So this is also disruptive to transportation. And then the self-driving cars will be maybe substituted by self-driving or Uber drones and things like that. So these are just some examples of how we need to think of it. And this is a self-driving car delivering for Domino's Pizza. I think this was during the COVID environment, and you can see that it brings the pizza with no driver in the car, so there's abundance of safety. And so it's self-explanatory, and this is what's happening in the future. Of course, with all of this, you have the danger of what if this self-driving car hits a pedestrian, which happened, and it killed a cyclist. Who's responsible? Is it the car? Is it the manufacturer? Is it the company running the car? And so there are regulatory issues that we are facing just in all these new industries. This is part of it. And this is just ideas of how to go about regulations. I'm not going to go in detail in it, but Grossman suggests that if we go to transparency, accountability, and let people do their work, but be audited very strictly, rather than going through the red tapes of bureaucracy, and which takes a lot of time. So these are how the regulatory people are looking at in how to face these new technologies that are coming out and new business models. We have to be worried about what's happening, and some people will be disrupted, some will be completely dislocated and become completely irrelevant. As I said, we have to be flexible, agile, adaptable, and always innovating. And with that comes a continuous struggle that we endured for the last more than 10 years, I don't know, 11 or 12, with Walid Aouf and Dardiri, our champion, who really carried the torch. And with that came a lot of failures and successes. And through the failures, you learn and you move to the successes. Of course, there were lots of blind spots. You need to learn from other people's experiences, and you need to have a good team to be able to try to avoid much of these blind spots, things that you don't know. You either have to learn on the job, especially when 10 years ago we were pioneers, and at least in our market. And we gained a lot of experience and created a very robust team with new talents and new skills along the way. Also ego. I'm the best guy, I'm an expert, we've done that before. Also, I think these are two things that can bring businesses down. I'm finishing up. I like this clip very much about virtual reality. There's augmented reality, virtual reality, and look how, because when we studied in medicine, it was of course completely different, of course, and now you can see all these technologies and the immense potential for the future. So I end by this, and thank you very much. I hope it was worth it. I tried to go as fast as possible. Maybe we can have other sessions that are more detailed to specific parts of this environment. So thank you so much.
It was great.
And
thank you, Dr. Wael. Thank you for your time. Questions quickly, Kida. What do you think has been the biggest bottleneck to more widespread adoption of telemedicine, unlike adoption مثلا زي في البانكينج والايكونومكس والكلام ده? What's the biggest bottleneck worldwide, maybe, or in Egypt specifically?
Yeah, so there were a few questions around this. Okay, yani, I think Mr. Shafiq, Salma, Amir, Ahmed, Aya, Nada,
yes.
Nader. It all goes around this. Now, I've shown the slide where it shows the different challenges, but I think there are some things related to Egypt in particular, and some things in general. In general, it's liability. Healthcare is much more dangerous in experimenting because of liability issues. In banking, you can lose money, but there's always insurance and all of that. But in healthcare, you really cannot experiment with patients and use patients. So liability is one of the important things that always needs to be in mind. The other thing is the regulatory. And it's important to have regulatory because you need to be on top of things. And this is a debate by itself. So as Grossman said, there are two ways of going about regulations. Either there is an entity that would provide a license and an okay to go ahead with implementation. May that entity be different in different countries, like the Ministry of Health or the Ministry of whatever, or the authority of something. But usually this takes a lot of time, and this is what's been happening around the world. For instance, in the United States, you are not allowed to practice as a physician unless you get the license of the state. So if you're practicing in New York and you want to go and practice in California, you need the license of California. And when telemedicine came, so even within the same country, you have regulations, but they sorted this out. So you can apply for a telemedicine license that for different states now and all of that. So they worked through that. So who is allowed to practice telemedicine? Who is what types of devices are you allowed to use, and what hospitals can use it in clinics? And so there's a whole regulatory body that, and it will keep on changing. This is the problem. So that as technology improves, technology will change much faster than the ability to implement. And this was the problem with healthcare. So, so what Grossman was suggesting is let people try or use some technologies that are reasonable, and you audit them, you check on them. He was not talking particularly about healthcare, he was talking in general about new disruptive technologies. So, but it is still not sorted out entirely, so regulatory is very important. Who's allowed to practice medicine where and what specialty? And as I said, it's not one thing, it's not a tool, it's a discipline. And I think this will not be sorted out entirely unless healthcare has been taken seriously as an industry rather than as a service or a business. And then industry is a much bigger magnitude. And I think with the COVID, because one of the questions was COVID, I think the COVID showed people that health needs to be addressed as an industry. As an industry means that a country needs to understand its strategic requirements of healthcare. And under these strategic requirements, this industry runs, and it will be given to different businesses to run it, but with a specific order of interest. You don't need to get shortages of this or of that, or you need how many doctors doing heart, or how many doctors. So it needs to be run in a more holistic way to be able to have a good society receiving good health care. So it needs to be run as an industry, which could be an industry is different than a business, because a business needs to make money, while industry needs to fulfill a strategy. And it's more on a bigger sort of society, whether it's a country, a city, or a nation, or an Africa, or whatever it is. And the next thing in the challenges are the tribal issues, under which comes fear of disruption, fear of competition. Am I going to lose my job? Are people going to come to my clinic? Are people going to like telemedicine? And we've been all through this over the last 10 years with different forms, but it is the fear of disruption, even with the most sophisticated doctors. You still have them, they have their own comfort zone, and it's difficult to move out of the comfort zone. Especially that you have some technologies now. I would say, unfortunately, scoring, they're putting like stars. This doctor is 5 stars or 3 stars, but according to patient liking. And in medicine, in my humble opinion, this is sometimes is misleading, and when it's misleading, it's dangerous. It's fine with other industries, products or banks or ice cream or food or whatever. You are entitled to your own personal impression. But that really is very dangerous when you put it on a medical excellence. Some doctor may be a little bit aggressive with patients, but he's the best surgeon in the world. And so this is also another debate, how to, and this is part of the challenge that affects doctors of this tribal, and I'm afraid of disruption and competing with the actual norm, which I'm comfortable with. Particularly for Egypt and other areas as well, is, in my mind, connectivity. If you don't have quality of service, how would you be able to deliver good healthcare in time when you don't know if you have connectivity at this time or not? And this goes both ways, at the provider side and the receiving side. So quality is service, whether it's bad or good, but it needs to have a quality. If it's medium, it's medium. If it's super, it's super. And this was one of our biggest headaches. Because, as I said again, in healthcare, sometimes a transaction needs to happen now. And if it doesn't happen, then problems of healthcare will happen. It's different than banking. If you go log in and the system is not working, you can go to the bank the next day or open the system the next hour or whatever it is. The amount of loss is not as much. So I try to summarize these things in this sort of, I hope I didn't miss much, but also it will be different from one discipline of medicine to the other. So again, as I said, telemedicine is not one thing. Doing telemedicine to an outpatient clinic is different than doing it to an ICU. It's different than doing it to a heart patient or a skin patient or radiology. Or so each one of these disciplines have different norms and acceptances. It's not all zero-sum game. So it is more complex than other industries. And as with others, we've been trying to push it forward over the last 10 years, and we are we achieved reasonable success working with Ministry of Communication, Ministry of Health, and implementing different projects. And as I said, now we have more than 120 sites, I think. We worked with, because one of the questions, Khalil, was the private sector. Yeah, we worked with. Yeah, we worked with hospitals. We worked with clinics, individual clinics and polyclinics, and we worked cross-border with providing to other countries and getting consultations from international hospitals, and each one of these disciplines had its challenges. Because if you go cross-border, it's another legal issue and another regulatory issue. You have the geo-block, of course, so countries can just block you from going there. So if you don't have the regulatory acceptance from another country, you cannot cross their border electronically. They will block you. We have experience in that as well. So, but it's different than the in-house experience. So as I said, there are different forms of business models. You need to really know what you're doing. And we were always worried, as I told you, Khalil, Omar, as we discussed many times, that we were always worried. We were flying below the radar because we were always worried that other people will come and destroy what we have done with idiotic implementation. Yalla na'mal, and let's go and do it, and all of that. And then it will reflect on all the industry. Of course, there's data security and hacking and all this. So many stuff going on, and we're always worried that if we are visible, we will, and other people will come in the field, and then we took it among ourselves to say, okay, let's start working. But it took 10 years, and I think now, again, one of the questions, yes, I think now COVID opens the doors to others, and we are willing to help others, work with them, cooperate, collaborate, and using their experiences and ours, and moving forward with other things. Yes, COVID, I think, may open the door, but we should also stay careful. We don't want to scare people away from the practice. But I think it's coming, and I think it may come faster. It's just the business models. What you really want to do, you always have to keep, because I'm a physician, so quality of service is number one. Who delivers what where? And this is what always scares me, because if you have a bad doctor who delivers bad medicine in his clinic, then when you open him up to he'll be disrupting that. Is this our responsibility? I don't know whose responsibility. So these are still things that are open above. We of course at Telemed have solutions for this. All that I've said, we haven't sorted everything out, but we have achieved good milestones in many of these challenges by different application and implementation models, and we're happy to talk to others. And so I think I've answered some of the...
Yes, I think you answered cumulatively half of the questions. Legally, have you been able to get any legal approvals of service, any limits on that? عشان في كم سؤال كده عن legalities, if you want to talk about that. And the other thing is, this system makes it everything is very documented. This is a liability where the practice is with minimal liability in Egypt and lack of documentation, as we know, the challenge we have.
Yeah, as I said, we tried the private part. We were not happy, they were not happy, but it will come along. But there are rules, as you said. Security is very important. data security. And remember, as I said, there are companies whose own business is hacking. So it's not just a nuisance, it's a company that makes money by hacking. And this is a common practice in the US. And hacking is not a very difficult, even with the best security, but you have to keep on, and even now, artificial intelligence is working on devising ways to hack. So it's a big industry, hacking and taking data. And what they're doing really is they are getting into systems, hacking that system in a smaller hospital, and saying, okay, give me $50,000 and I will release your data and something like that. And hospitals find it more economic and best to continue practice and give them the money and so on. This is another layer. So security is a layer of that. In Egypt, as I said, we tried different models and we're working with different models. And so now we're working with the government for several years. And that's providing two things. One, it is secure data, because we're working with Ministry of Communication and Ministry of Health together, and Ministry of Higher Education. So between these three entities, with all the challenges that each entity brings, we have a sort of a way of doing the work with them and implementing under their rigorous audit and regulatory operations. And through that, we achieved the milestone of implementing telemedicine to hundreds of sites and to thousands and thousands of patients with different models in this. And I think now everybody in the government is also interested in this. They moved an inch better, I think, and it may open to the private business even better in the near future. That's what we're trying to push as well. So they are more comfortable now with what telemedicine is. They are not still satisfied with the regulatory and what could happen, but we are still moving along that front. So I think maybe we can help others, or with the help of others, or whatever, we can keep on challenging what's there, because it is a huge transformation, and it's not going to be easy for anybody or for us or across the globe, but I think it's starting to happen. The new phase is starting to happen, especially that the COVID is not going to go away pretty soon. You need to have remote.
Do you have any explanation or any advice for those who are working in healthcare provision? The elective demand on healthcare has decreased, and yet the adoption to even normal clinic visits virtually did not keep up with this deficit, and if you know what I mean. So there has been a mega decrease in elective hospital care and clinic care, yani wellness visits, visits that are not non-urgent visits.
Yet telemedicine did not catch up.
Yes, in my opinion. Yeah.
Okay, yeah, it's very simple.
The worldwide, yeah.
Worldwide is a little bit different. In the States, it's flying. It is now the norm. It is the norm. بعد الكوفيد, it is the norm. في الأول كان في there was some regulations to what you can do to a new patient who you never saw before, and all of this specific diseases. So as again, telemedicine regulations is a little bit murky here. So if you're seeing a new patient, it's different than if you're seeing a patient that you have been seeing before. And if you're working out of a hospital, it's different than if you are working from a telemedicine provider company or something like that. So these are different regulations. But it shifted a little bit more. So now hospitals, so telemedicine companies are still not allowed to do more than what they were doing. But hospitals are definitely moving towards, or actually are practicing telemedicine instead of the regular clinics and follow-up clinics to patients they already know and have seen before. So this moved very fast. Why isn't this happening in Egypt, and why it may never happen? For a simple reason, we are all physicians. Physicians have access to our mobile numbers and our WhatsApp, and they simply would call you up or would send you an image. And
so the barrier of entry is not is not there in the first place. And
no,
it's,
it's just the barrier of monetization.
Yes, the barrier of monetization.
So you cannot really do business because it's done in a simpler, although unregulated way, because you really should not be using WhatsApp to move messages. Even if it's encrypted, it's not your pot. So you do not have the right to store patient information according to HIPAA on these. It's not your site, it's not the patient's site, but it's the patient who's pushing this towards you. So you're not really, it's two-way how to legalize that or how to judge that. At the same time, you really should not give a telephone consult. That is not telemedicine. But this is the practice in Egypt. This is one of the things that it's going on. It doesn't depend on bandwidth, so it's abundant. And doctors will not charge for it. That's another thing. Because we went into this early on, and the doctors themselves and the clinics said, no, we're doing this. This is part of our practice. If I start charging, then the patient may go to some other doctors who doesn't charge or things like that. So it doesn't have to do with us. It has to do with the norm of the practice and how it is. So I think this is why there is not much adoption to classic telemedicine implementation. There are ways to make it more, but that's another discussion. So there is still a slot for telemedicine in clinics and in polyclinics and hospitals, but it's a different model. We worked on it, and we have, but that's a different. It needs a larger platform or much more time to discuss how we can crack the nut, as they say in this.
طب a quick يعني advice كده أو motivation for people working in health and healthcare as an industry and not only providers. And can you become both a physician and a business, an entrepreneur? Should you decide this or that? Tell me your thoughts about that.
Yeah, I want to also, before I say that, there was a very nice question or a couple of questions from Abdel على geographic data, and of course I'm addressing Abdel, everybody else. This is the most secure and data that needs to be very well secured, and this is why this is a big debate between even in the Western countries who should own this data, and because of if you align geography with genetics, with healthcare in one pot, who owns them really needs to be very scrutinized, because this tells you everything about the ins and outs of the society you're living in and the nation. So yes, it is under, the question was, is it used? Yes, it is used, but it is under tremendous amount of security and scrutiny in all nations of the world. And this is actually one way they are using to monitor, keep your distance in the COVID area through your mobile signals. So this is one way of looking at it. So in answer to your question, yes, there is tremendous potential in the healthcare realm. I think, as I said in my title, and I meant it, trying to move to healthcare being an industry with with that strategic notion, I think that now COVID is going to move all governments across the world to look at health not as a business or as a service, but as a strategic industry that needs to be well anchored in each geographical region and each nation. And this opens a good window to be able to provide services that not necessarily are pay as you go, which is the most abundant transaction in Egypt is pay as you go, for private and otherwise. At the same time, I only hope, I am pretty much sure, if the wave of the bandwidth in Egypt and the quality of service is better set, we will have an abundance of opportunity. And I know there are lots of innovators out there, whether they are doctors or technologists or whatever, it doesn't matter. Yes, I am. In my mind, I never look at things as being hopeful or pessimistic or optimistic. I'm a pragmatic, and I like to go after one thing, and you have to be perseverant. It's a struggle, and you will have failures. But if this is what you want to do, and what you like to do, this is the most important thing, I think, Khalil, you really need to understand that this is not going to be a couple of weeks or a couple of months, and then you get an app and everything is happy-go-lucky, and you get your picture on Facebook and make millions of dollars and put them in the bank. I hope, if someone strikes that, that would be fantastic, but at least this was not our experience in this run. So you have to put the drive in, select your team. The most important thing is team. The other most important thing is time. And so I think the time is now with this COVID new era. And select your team, go for it. Look at other people's failures, learn from them, talk to others, collaboration. You don't have to do everything alone. There was a Nobel Prize for partnerships a couple of years back. It's the most successful business model in the world is partnership, and it took a Nobel Prize. I can't remember the year, but it was a couple of years back. Look at partnerships. Yes, I think the next period of time will witness lots of change. We are willing to help others. We're willing to work with others. I'm willing to answer questions and help as best as possible. So,
great.
What do you have on your Khalil? I hope that was useful.
I think the more that like-minded people and people in the ecosystem talk, they would know that. I would like to thank طبعا Omar for making that possible and for having حد زي حضرتك يا دكتور وائل. It's very insightful seeing this journey. And you as an institution, will you be utilizing or have you been utilizing telehealth as a Magdi Yaoub foundation?
Yeah,
do you
definitely.
do that?
Yes, we do that regularly. It's amazing. Even Magdi Yaoub himself attends some of the sessions, and you would be amazed. And one of our busiest sites is Al Kharga, مثلا, في الوادي الجديد, and you'd be amazed if you see a family in Al Kharga and talking to Magdi Yaoub, and
wow.
And then they come and do the surgery, go back, and we check on them once in a while. But it is not simply a video conference, because you have to train the people here and there. It's not that difficult. I don't mean it, but it's, again, you need to look at all the business model you have. You would probably not start with the right one right away, but you need to learn from others, implement, adjust, and so on and so forth. And like any other new technologies, I hope there will be, there is an immense amount or space for innovation. I mean, if you take each discipline of medicine by itself, neurology, diabetes, cardiology, in each one by itself, there's tremendous amount of so it's not one thing that you need to do different, an app rather than, no, it's an immense amount, it's a huge becoming, and lots of potential. You need to read, you need to listen to telehealth webinars, other things, TEDx talks, and understand how others are thinking, and look at your own environment and see how you can do, if you're into it. If not, it's fine. Don't get into something that you think it's a trend.
Okay.
This would be the biggest disaster if you just because it's trendy, I need to do it. No, you need to take it seriously, and if you do, I'm pretty much sure you will get rewarded. It will after some time if you're serious about it.
That's amazing. Thank you, Dr. Wael, for inspiring everyone. And we really, as you said, it's not as simple as if telehealth has been done, it has been done from the 1918th أيام Spanish flu, where people used to give advice by the phone. There is much more to that, as you said, and thank you very much. I think we covered most of the points. I would like even to do maybe a session later on covering even more questions and bringing on board people, the real heroes that are doing what you're saying, and listen to the stories. And this is very inspiring, and this is what I think Omar is trying to do with this repeated webinars. Omar, أنت معانا ولا؟
معاكم جدا.
طيب
عمر راح على ويبينار تاني.
عمر شغال في ويبينار تاني قبل الفطار، فرق توقيت.
Yeah, well, I would like to take this moment to thank both you and Omar.
Thank you, Dr. Wael. Hope you have a great day in New York. Stay in, stay safe. We thank you, Omar, very much for this amazing webinar session.